So I'll tell you a little bit about myself and where I come from, so you'll be able to see why I got interested in the metabolic syndrome and what are the risk factors we have to pay attention to. And this is the first part of my talk. Then later, after a couple other speakers will talk, I will talk about how to deal with metabolic syndrome, how to help our patients lose weight and be healthier. But the first part is the bad news. The bad news is our patients are taking medications that don't help with weight gain and staying healthy. So I promise you that I will talk about myself, because also, please, not many times I can talk to myself to many people. We as psychiatrists always have to listen, right? Anyway, I come from Harvard Medical School. I am a faculty there, a professor of psychiatry. And for the last 22 years, I've been at McLean Hospital. McLean Hospital is the largest psychiatric private teaching hospital of Harvard. This is also the oldest still active, still working psychiatric hospital in the United States. It was founded in 1811. 1811. So it's been a long time. They've been there. And I went 22 years ago, mainly for more training. I came from Italy via Canada, McMaster University. I went to Harvard and McLean to do my psychopharmacology training. And 22 years later, I'm still at McLean Hospital, happily. So I paid all my dues, meaning I worked in the inpatient unit. Always my work was a combination, it is still, of clinical work, research, and teaching. So now I've been for the last 14 years at the head of the specialty clinic, outpatient clinic for bipolar and schizophrenia. And we tend to have them referred to us, the patient that have been failing treatment, either psychosocial or medications. So we tend to get the most severely mentally ill. And of course, I was very happy when the newer antipsychotics and the newer mood stabilizers came out, because as you know, the first antipsychotics or typical antipsychotics, they worked, but really, patient didn't like it. I didn't like it because of very high neurological side effects. EPS, Parkinson's, tremor, tardive dyskinesia, that very often is not socially acceptable to have somebody having chewing movements or slow movements of the body. And so when in 94, in 1990, the first typical antipsychotic, clozapine, came out, there was really a new energy going into the pharma industry to develop new antipsychotics that will be as good as clozapine, meaning not giving neurological side effects, no EPS, no tardive dyskinesia, but helping even more with negative and positive symptoms. Unfortunately, we found out not right away, but that also the newer antipsychotic, the risperidone, the olanzapine, the quetiapine, you name it, came out with other side effects that are not any safer, meaning they can affect weight gain and the complication of weight gain. Actually, in a way, I was a pioneer on noticing that. In 2000, I had a study to try that I will show you to try to help people who gain weight on the newer antipsychotics. So now you know what I do. I'm mainly a psychopharmacologist, but my team is comprised of social worker, therapists, and I do believe strongly that treating the severely mentally ill, the medication can do the part, but the rest is also social. So even though I focus more on my medication, how to help patients, it's not to minimize the other part of the treatment. So what is the background of this increased metabolic syndrome risk in the severely mentally ill? Clearly, it's today recognized that psychiatric disorders are often an increased risk of medical comorbidity and higher mortality. There are specific studies. One, I am a first author that I published in 2009 that showed that patients with bipolar disorder have more metabolic comorbidities and, interestingly, more medical cost than healthy control. And interestingly, I'm not going too much into the study, but interestingly, the increased cost was because patients used emergency room and inpatient for diabetes, hypertension, medical problem than the controls. The background of that, how to interpret that, is that really bipolar patients don't take care of themselves. They only go when their diabetes is out of control, their blood pressure is out of control, and use much more expensive services to get treatment. Of course, cardiovascular disease is a leading cause of death in psychiatric patients. And some numbers here. Patients with schizophrenia have been found to die 11 years earlier. Now in the States, the average age is around 74, lifetime expectancy. Schizophrenic will die around 60 years, and not necessarily by suicide. That's excluding suicide, is for medical complication. And the schizophrenic also have another vulnerability because often they don't know how to explain themselves. The primary care doesn't have the time to go beyond the patient's paranoia. And very often if the patient say, no, I don't want this treated, my blood cholesterol is fine, I don't want this treated, primary care says, okay, I'll see you next time, and don't spend too much time. And has been shown even in studies that control schizophrenic who had heart attacks, how they were treated in the emergency room in the hospital compared to the general population. And people with schizophrenia had higher mortality and morbidity than the general population after heart attack, not because the heart attack was worse, but because the medical treatment was less aggressive. So that's another point, how to advocate for our mentally ill in the medical arena. Another number, patients with bipolar are 2.5 times increased risk for mortality compared with the general population. So these initial slides tell you our patients really are dying for medical reasons more than expected. Then we add the treatment, I was saying. Antipsychotics are widely used both for schizophrenic and for bipolar, for psychotic disorder, and in bipolar for mood stabilization or psychotic disorder. Unfortunately, we have learned the newer antipsychotics give weight gain, that increases the risk of type 2 diabetes, adult diabetes, increase the risk of dyslipidemia, meaning high cholesterol, high triglyceride, and the risk of cardiovascular disease. In our patients, and I have to tell you, never blame my patients if they gain weight or this, or say I want to go off the medication, because it's very hard. There is an epidemic in the United States of obesity on the general population. You imagine our patients on top of that have medication that increase appetite. How? So it's not blaming, but it's important to cooperate on trying to see what we can do to minimize this risk. Because the worst is when patients go off their medication because they're afraid that you'll be mad at them, or the opposite. They don't want to upset you. They are so close to you that they want you to be upset at them for them even considering stopping medication. And then they stop it. And then you find out from the emergency room that, hey, your patient here, they have stopped their medication a month ago. And then you say, well, wow, that's why maybe they skipped their last visit. They didn't want to tell me. And then, yes, so you have to start from scratch because now they are unstable without medication. Why people gain weight? In general, of course, is unhealthy lifestyle. What is unhealthy lifestyle? Lack of physical activity, the diet is not right, but don't minimize this, also increase sleep. You know, if a patient is sedated from their medication and instead of sleeping, 8 hours, they sleep 12 hours, that's 4 hours they really are using minimal calories, and that should be accounted for, how many calories they can ingest, or encourage them to get out of bed earlier. In particular, without going too much into the details, the antipsychotic that have stronger affinity for histamine, so the antihistaminic, the anticholinergic, and the serotonin affinity, also this lead to more weight gain and medical complication. And later on I'll tell you what are the drugs that have those higher affinity. This is a slide, seems complicated, but to tell you, if people gain weight, what happens? The body fat, the fat cells increase lipolysis, meaning they will get rid of free fatty acids. Not only they absorb the fat, but also they try to get rid of the free fatty acid. What happens in the free fatty acid? When there are too many in the bloodstream, the insulin sensitivity decreases, meaning the muscle don't use so much glucose for the energy burning. They use more of the fat, the free fatty acid that are available. So that increases the blood sugar. What happens in the liver? In the liver, if there are too many free fatty acids, the liver tries to excrete those, get rid of them. And what happens is there is a decrease of HDL, the good cholesterol, a decrease of that, an increase of the small, dense LDL. What meaning? LDL, they are small, so they go inside the artery wall more easily than the big fat cells. So induce atherosclerosis and deposit of fat in the arteries more than the HDL and the large cholesterol. Going back to this, what happens again if the muscle doesn't use so much glucose? there is decreased glucose utilization, means more transformation of free fatty acids, and then more production of glucose. So less utilization and more production of glucose, meaning you have hyperglycemia and atherogenic lipids. And this originates with increasing body fat. Another thing I want to say, I have to time myself. Okay, I have a clock in here. I'll try. So this is an interesting slide because if you consider 0 the time that a patient is diagnosed with diabetes, the changes in the body don't happen 20 years before. When we catch patients who have diabetes, already a lot of changes have happened. And so nowadays, it's more about preventing diabetes than only treating declared diabetes. So what happened 20 years before? When people start gaining weight, they are obese. The body tries to keep the blood sugar low with increasing the insulin production. It succeeds for a while, you see? So, but at one point, then the insulin level cannot go any higher, so stays plateau, and you develop insulin resistant. And what happened is, for other patients who are very obese, their insulin level sometimes decreases, and then when you got diabetes. What happened in the same time, again 20 years before, the blood sugar is normal because even though they are obese, the insulin level increases, so the blood sugar is maintained normal. Maybe a couple years before the start of diabetes, you can detect a non-fasting postprandial after eat, maybe an increase of the blood sugar. But fasting sugar is normal. But then because the insulin level decreases, so the pancreas cannot excrete any more insulin, then they declare diabetes, that even the fasting glucose is abnormal. So how we can work in this part, because right now medicine is working here. After people have diabetes, already the insulin level is low and the body cannot metabolize glucose. So we have to be working much earlier. So to make a more complicated story more complicated, severe mentally ill is complex. It's not only neurotransmitters. It's now immunologic, is now endocrine, is now vascular function. Everything can be affected. In the U.S., there is, since 2007, is mandated to obligatory to monitor any patient who's on an antipsychotic, even though I have to tell you, should be mandatory for any patient who's gaining weight on any psychotropic medication, I will say. But now it's mandatory only for people who are on antipsychotic and gain weight. So the metabolic syndrome, the definition of metabolic syndrome is there are 5 biomarkers to define metabolic syndrome. Waist circumference, triglyceride and HDL, the body mass index, the BMI, blood pressure, and glucose. So we did a study really to see what is the prevalence of metabolic abnormalities in patients who are inpatient at McLean and are taking psychotropics. I want to see what is the rate of metabolic syndrome around our patient compared to the general population. And we try also to see if there is any particular treatment that is worse, higher risk for metabolic syndrome. So we looked at 350 consecutive admissions to McLean. We collected data like what medication they were on at admission, both psychotropic and non-psychotropic, their age, sex, their diagnosis, the illness onset, the treatment duration, the days of index, how many days they were inpatient. Much time. Oops. So, as I say, the markers of metabolic syndrome. One patient is considered having a metabolic syndrome. That means they are high risk of cardiovascular disease, to develop cardiovascular disease. If they have 3 or more of these risk factors. Abdominal obesity, if the weight is more than 1 or 2 centimeters for men, 88 for women. If the triglycerides are more than 150. If the HDL cholesterol, if the good cholesterol is less than 40 for men, less than 50 for women. If the blood pressure is above 130 over 85. If the fasting glucose is more than 100. So any combination of these 5 factors, if there are 3 of these present in one patient, that patient has metabolic syndrome and puts that patient at high risk of cardiovascular disease. So this is the statistic. Let's jump onto the results. These are mainly the demographics. Demographics are of the 350 patients, 71 were schizoaffective, 105 bipolar, schizophrenic 82, mood disorder in general that include major depression, unipolar depression, and others. More than half were men. They stayed on average 12 days. Our psychiatric hospital is acute care. Okay, we are not a long-stay hospital. It's mainly for treatment of acute relapses. The age of onset of illness in these patients was in their 20s. So this is our population of the 350 patients we reviewed. And metabolic syndrome. I'll point out that metabolic syndrome was highest for patients diagnosed with schizoaffective, 45%. To remind you, in the United States, the metabolic syndrome is 25% of the population. So we are quite higher than the general population. So schizoaffective, bipolar, not too bad, but still the schizoaffective have the one with the highest. Why is that? And remember, this is averages, so I'll show you that some between bipolar and mood also they have a high metabolic syndrome by age and length of illness. But why schizoaffective? Everyone was surprised when we look at this. Remember, schizoaffective are the ones that have everything. They have anticonvulsant, they have delirium, they have one antipsychotic, maybe a second antipsychotic, maybe they have the clozapine, maybe they are not the really lead the olanzapine to respond. I see them as the one that we put in the pool because they don't respond, so we keep hitting them with a lot of medication. And as you see in other slides, higher number psychotropic, higher risk of metabolic syndrome. But without telling you too many things in advance, let's go to the next. Again, male interestingly, had higher chance of metabolic syndrome than women. Treatment duration. We had some patients who were treatment naive, the first psychotic break or the first manic break. And look, their metabolic syndrome is very low. Also, they're very young. They're mainly in their early 20s. Actually, it's below the general population. But look, with treatment, 3 years on treatment goes up 23%, 10 years treatment, 25%, 10 years of treatment, they go to 40%, really much above the general population. So years of treatment is associated with higher risk of metabolic syndrome. And this is the same in a graphic manner. Treatment naive, 10 years, and percentage of metabolic syndrome. Polytherapy, as I already told you, but clearly, polytherapy at admission, almost 50% of the people who have many psychotropic on board have metabolic syndrome. They are the one at higher risk. Atypical only, they go to 37%. Typical only, 33%. No antipsychotic is actually below the general population. So again, polytherapy and atypical and typical, they are higher risk of metabolic syndrome. And this is in a graphic manner, polytherapy versus one atypical, one typical, and not antipsychotics. And what are the worst offenders between the medications? In our study, actually is similar to what came out from the FDA committee. Clozapine, patients on clozapine have the highest metabolic syndrome, 57.9. Olanzapine, haloperidol, remember, because this was considered to be, let's do a typical. Even typical, they're high risk of having metabolic syndrome. Quetiapine, aripiprazole, risperidone, non-antipsychotic. Actually, this, in a way, replicated what the FDA said. What was the ADA consensus on antipsychotics? This was exactly a replica of what we saw. Conclusions. I'm doing good. So, psychiatric patients are at increased risk of metabolic syndrome. Unfortunately, often these patients are very vulnerable, more than the general population, especially the chronically mentally ill, because even if there are resources out there, they either don't have the money, they don't have the skills to reach these resources. Even they don't have a primary care sometimes because they are too paranoid. Or like the bipolar, they feel so good why they should see a primary care and be monitored. So as psychiatrists, sometimes we are the only MD or therapist are the first line that can help these patients. We have added another layer of responsibility to psychiatrists and psychiatry workers, because for whatever reason they come to see us, voluntary or involuntary, we are the one that have to monitor. We have to monitor their weight, their fasting glucose, their cholesterol, and American guidelines are a bit, I think I have in the other talk, on the other talk I'm about to monitor. But we are the first line, more responsibility than ever. And but also, we are the one that can convince or have the responsibility to talk to our patient. Did your patient, I have a very bright bipolar patient who comes here, no, my primary care want to start me on a statin for my high cholesterol. I told him no. I said, why? I don't need another medication. I say, do you understand what you are doing to yourself? You are decreasing your life, your lifetime length of many years, and a lot of suffering if you don't use a statin now. I make it very dramatic. In a way, I want to scare them, but also encourage them to go back to their primary care and say, after thinking about it, why don't we start it? Also, of course, novel psychotropic, new medication that help with minimal side effects, both neurological side effects and now metabolic side effects are needed. But for now, we have what we have, and on my second talk, after 2 talks, I'll talk to you how challenging it is to help people to stay healthy. Thank you.